Welcome back, everyone. I hope everyone is caffeinated and alert and rested. It's my absolute honor to hand over to our afternoon chair, Ruth Driscoll, the Associate Director for Policy and Public Affairs at Marie Curie UK. Thank you, Ruth.
Thanks so much, everybody. I'm aware you're probably in your late afternoon low sugar lull, so we'll try and keep this final session as lively as possible. And we've got a very exciting and expert panel for you, but I really want to encourage you all to keep to time so that people have a chance to ask some questions at the end if they would like to. I'm going to start by just making some opening remarks about the revolution that we want to see at Marie Curie. Some of you will know us for our nurses who care for people who have palliative and end-of-life care needs, either in our hospices or often in people's homes. But we're also a big funder of academic research, in fact, the largest non-government funder of research into palliative and end-of-life care, and it's some of that I particularly wanted to share with you today. So, the theme of today's session is ensuring healthcare is more accessible and closer to home, relieving pressures on hospitals. So we're picking up that shift in the 10-year plan from hospital to community in this session. And the first thing that I wanted to say is just to share with you the picture and how it feels for people who are reaching the end of their life. So the data that's on this slide is based on a nationally representative sample of the population. And we asked them, they were people who died from non-sudden causes, and we asked them about what their experience was of quality of care in the final year of their life. So it was a survey of bereaved carers, close family carers in most cases. And I think it's quite a sobering set of facts for us to reflect on. So it was a picture very much of gaps in 24/7 coordinated care in the community for people reaching the end of life. Nearly 1 in 5 of those who died said that they'd had no contact with a GP in the last 3 months of their life. Barriers to accessing palliative care medicines were common, especially out of hours, and fewer than half of the respondents to this independent academic survey said that they'd had a key person coordinating their care in the community. They felt that recognition of them as having palliative care needs was coming much too late, and 1 in 4 of those who died either probably or definitely didn't know that they might die because of their illness. And this is despite it being a predictable cause of death. They had a diagnosed condition and it was life-limiting. Half of the respondents were unhappy with at least one aspect of the care that the person who died received, and 1 in 9 of them made a formal complaint about that care. And I just think it's really important for us to recognise that that is the real lived experience of people trying to get the care and support that they need when they have a terminal illness. The second thing I wanted to just share with you is some information about the impact that this is having on system pressures. So this might be a little known fact, but people at the end of life are a really significant factor in system pressures on acute services in England. So this is based on official data. 61% of the people who die each year use an ambulance in the last 3 months of their life. Over half of them visit an A&E department once or more, and 6% of them have 3 or more emergency admissions in the last 90 days, and 69% of all the people who die spend time in hospital during the 6 months before they die, and they're occupying a total of 8.4 million hospital bed days each year. So, why is this? The big picture here is that hospital is still the place of death for many people, even though we know it's not most people's preferred place of care. What you can see on the right-hand side of this slide is some pie charts, and the question that we asked people was, where would you prefer to die? And on the far right-hand side of the slide, you can see what people responded who were in the last years of their life. And you can see in navy blue that the biggest preference is is to be at home at the end of your life. And that preference only changes slightly when you ask people in the wider population. So the wider population also has a really strong preference for home as their place of care at the end of life. But on the other side of the slide, you can see the actual place of death of many people. In fact, in England, 42% of all deaths are taking place in hospital. Only 5% take place in hospices, like the ones that we run at Marie Curie. 21% of them take place in care homes, just to give you a picture of where people are dying, because that's a key measure of whether we're achieving people's own preferences, what matters most to them personally. And then on the next slide, I just wanted to give you a picture of how much money we are spending as a nation on this cohort of patients, because, again, it's quite a sobering picture. So currently, we're spending about £12 billion a year in Britain on healthcare for people in the final year of life. And we're currently spending 5 times as much on supporting people in the final year of life as hospital inpatients as we are on supporting them through primary care, community health, and hospice care combined. So this picture comes from some research we funded from the Nuffield Trust and the Health Economics Unit. In the context of the government's plan to shift care from hospital to community, the mountain feels quite steep to climb here for our group of patients. But the good news is there are some models which are live and rolling out across the nation, which are actually making some really significant inroads into this challenge. And I'm defining the challenge here as improving, I guess, 3 kinds of outcomes. So we want to improve access and quality of care for people with palliative and end-of-life care needs. We also want to improve the experience for their loved ones, so for their often unpaid family carers. But we also want to better manage these system pressures. And there are 3 models of care that I just wanted to really briefly share with you, because I think they give you the good news of what can be achieved if we have the will to do it together. So the first of these models, just checking my slides are ticking through there, is the 24/7 single point of access to palliative and end-of-life care model. So this has been a recommendation of NICE for almost a decade, and the idea is simply that when someone has a terminal illness or they're caring for someone who does, they are given a single phone number which allows them to connect to a palliative care nurse. It's usually a band 7 with some palliative care expertise, and that person is able to very quickly and easily connect them to all of the different types of services that they might need, whether those are voluntary sector, statutory, might be health, might be social care, might be the need for social prescribing type services, financial support, for example. These models do exist in different parts of the country, and the one that I've shared on the slide here is one that exists in Merseyside. It was set up by a group of local providers who found that people were reporting having multiple phone numbers given to them that they stuck on their fridge, but when it came to nights and weekends, none of them were open. And as a result, many of them were coming into hospital. And so they took 44 local services, managed to bring them together in a much more coordinated way, accessible through one phone number. And as a result, they've increased the proportion of people who are being identified early as having palliative care needs. They've managed to decrease the number of emergency hospital admissions, and they've also managed to achieve cost savings of 17 million in the first phase of rolling out that model in Merseyside. So the cost savings and the cost effectiveness is real for the system. The second model that I want to just briefly share with you is a really simple one. It's about paramedics carrying just-in-case end-of-life care medication. The challenge in Wales here, in this instance, was that a lot of paramedics they're trained to treat people and get them quickly into the care that they need. And in fact, that was resulting in a lot of people who were at the end of life not being able to stay at home when that's where they wanted to be. And so what they did in Wales was they trained and equipped ambulance service paramedics to carry medications which palliate end-of-life symptoms like pain, anxiety, breathlessness, and nausea. They placed these on emergency ambulances, and they also trained the paramedics to feel confident and competent at using them. They achieved similar resource savings on hospital and transport use. They improved patient outcomes, had really positive patient experiences, and there were also really tangible benefits reported for the workforce as well, who just felt better able to do what they knew needed doing for these patients who were dying at home. And the cost savings are really clear in that model as well. And then the final model, which I hope will appeal to both those of you working in the community and those of you who are working in A&E and acute settings, is called the Responsive Emergency and Community Assessment Team, REACT for short. It's in Bradford Royal Infirmary. This is an area that has very high levels of deprivation, a very diverse local population. And what they're trying to do here is make contact with people as they enter the front door of A&E. So as people come into Bradford Royal Infirmary, if they appear to be at the end of life, they get immediately assessed by a palliative care consultant, and that person decides what happens next. It may be possible to support them to get back home. They may need a hospital admission. They may need connecting into hospice care at home or specialist palliative care services in the community. But that decision is made on the spot using all of the information they can gather from medical records and so on. And because of the big challenge about stepping people down from A&E and acute settings, they use a virtual ward model here, so they can support people for up to 72 hours through the virtual ward model. That person has access to a palliative care nurse on the phone. There is a multidisciplinary team who make sure that their care is planned carefully over that 72-hour period, and they put in place the right package of support. And the impact on outcomes for patients and for families and the system are really incredible in this sort of model. So you can see on this final slide, the patient and carer experience has been improved. They have managed to reduce the average number of unplanned bed days occupied by people at the end of life. They've managed to cut them in half through this model in that hospital. And they've also managed to achieve cost savings of between 1.7 million and 2.2 million in the first phase of the implementation. And you will laugh at how conservatively they estimated the cost of those hospital bed days. They had a cost of £154 per bed day. At least for those of us working in London, that is a laughable figure. So the actual cost savings are probably much larger. So they've also managed to really make some inroads into unequal and inequitable access to palliative and end-of-life care services for that local population. So they've managed to make sure that the people who are accessing this service are representative of the wider population in Bradford. They've managed to improve equitable access for underserved populations to specialist palliative care services locally as well through this approach. So I hope it's nice to reflect on the good news as well as the challenge. And I just wanted to end by sharing with you the promise that's made in the 10-year plan for people at the end of life. It's a really exciting promise from our point of view. People nearing the end of their lives often don't have the support they need for a good death in the place of their choosing, which for most people is their home. So the vision here is that community-based advice and support will help more people die in their home, while community teams will work with care homes and paramedics to share care plans to avoid people being taken to A&E by default. And teams will include hospice outreach and palliative care professionals, and rapid response teams can also help with symptom management, including managing pain. So that's the revolution that we would love to see, and we're really excited to have the chance to talk to all of you about that today in a little bit more detail. So I hope that helps bring alive the challenge a little bit for at least the cohort of patients that we're working with. And I wanted to hand over now to the first of our really exciting presentations. So this presentation is about scaling a virtual ward model across the system in Maidstone and Tunbridge Wells. And we've got Naresh Nagalipalli, who is an advanced clinical practitioner in Maidstone and Tunbridge Wells Trust. And we've got Jonathan Lewis, who is Managing Director of Lucy UK. So over to you guys. Thanks.